had a kid one time. It was like my first week as a dentist. I walked him to the front. The kid was numb, and the parent was brokering the next appointment, and the kid walks over and hands me something. And I looked down, I'm like, what is that? It was a piece of his tongue.
Oh,
he
wow.
bit a whole piece where it was numb and just handed it to me.
A lot of parents are collapsing into this parenting to comfort, and they don't want to stress their child out, as if any distress from the child is so problematic that it overshadows their long-term health interest. And it's very common.
My personal view is that in America, what is marketed toward babies is very high sugar, and it causes a lot of dental cavities. Some of the things that you just think are, because they just keep telling you, like, this is good, the TV tells you this is a great product, this is a good product. It's like, it's yogurt, but it's more sugar than yogurt. The muscles are the key.
They're acting all the time.
Mm-hmm.
Like, we're not chewing all the time, but we can clench our teeth a lot, and then that's going to change, get larger masseter muscles on the sides.
Yeah, exactly, yeah.
Welcome to the Dr. Thornburg Wellness Podcast, where pediatrics meets functional medicine, blending science-backed insight, common sense, and a touch of shamanic wisdom from a father of 8. Hi, I'm Dr. Brian Thornburg, and today I have Dr. Jennifer Hughes. She is a pediatric dentist. She takes care of my children, and she does a great job for a lot of my patients in my practice. And I had a lot of questions about pediatric dentistry, about fluoride, about braces, about when a child should first go to the dentist, about using sealants, and all the questions that I received from my parents in my practice. And so I thought we would go right to the source, and a very knowledgeable one at that.
Oh, thank you.
Hi.
Very nice.
Yeah. Well, I like to be nice. Yeah. Pediatricians are generally nice.
Yeah, it's always better. Yeah.
That's what whenever the drug reps come by, they're like, oh, the pediatricians, I always like going to see you guys because you guys are nice.
Aw.
Unnice.
Yeah.
So first thing I want to do is I asked you if you were a DDS or a DMD, and you said you're a DMD. Why? I know there's two different degrees that are dentists, but I don't know why some are DDS and some are DMD.
Some are a little more medical focused, but I think it just generally comes down from what school your school was birthed from. So basically, I think it was Harvard and somewhere else were the original schools, and then it just kind of went from there. So University of Kentucky is where I graduated, and we were it was in the 90s, and I graduated in 2000. And we were very medically focused. And so we did a lot of comprehensive care, which meant we were looking at the whole patient approach. And we did classes with medical students. And so it wasn't as dentally focused in the first couple of years as medically focused. So
okay, so the DDSs are more
supposedly. I think over time they've kind of meshed into about the same degree, but that's my understanding. Yeah.
Does one tend to go more academic, like a PhD versus a PsyD? The PhD would tend to go more academic, whereas a PsyD would be more clinical.
I think they're pretty much the same now. I don't think that either one is trying to say we're more of like the DO versus the MD. Like I think they're pretty much just the same degree now.
Okay.
Yeah.
They're just probably, and you take the same boards.
Oh,
and, everything else is
all
the same.
Yeah.
So nothing changes. Okay. And it's just for people, you go to 4 years of college, and then you do 4 years of dental school, and then you're not a general dentist. So does a general dentist hang their shingle right after the 4 years?
Correct.
Okay.
Yes.
But then you did do they call them fellowships?
Residencies.
Residencies.
Yeah. So I first did a general practice residency. So after 4 years of dental school, you can go directly into private practice, or you can take a GPR, which is a general practice residency for general dentists. And some of them will be focused in different ways. And so my GPR was actually in a children's hospital. And we did a little work in the VA. You do a lot of oral surgery, and it's just an extra year of training. And so I took that year to kind of build my resume, because I knew pediatric dentistry was going to be a very hard specialty to get into. And then I applied to pediatric dentistry. And then from there, did a 2-year residency specifically in pediatric dentistry at the University of Tennessee at Memphis.
Okay. And does that, the residency in pediatrics, so does that involve? I mean, obviously general pediatric dentistry, but then also sedation because a lot of kids have to be sedated.
Correct. So we learn sedation. We do oral sedation, IM sedation. They're now doing IV sedation in the training program with anesthesiologists. We did a lot of hospital-based dentistry where the patient is completely asleep. We didn't do that part of it, but we did the dental part of the anesthesia. We did rotations through anesthesia where we actually did the intubation. We did the IVs. We didn't push the drugs there, but we were part of the team. We did emergency room stints where, we would help with emergencies in the children's hospital, like codes, and our job would be to write on the board for the code. And I did stitches in the ER. We did a lot of different rotations around to learn all aspects of medicine. Yeah.
So when you say stitches, not just in the mouth, but just
Correct.
other parts of the body.
So it was our job to do some facial lacerations and things like that. Yeah.
Okay, cool. Now, I have a lot of different questions. So how many times have you seen a baby born with teeth?
Maybe 6 or 7
6 or 7 times.
Yeah.
I've never seen it.
You've never have?
I've never seen a baby born with teeth.
So interesting enough, when I was a resident in pediatric dentistry, the thought was that these teeth were not teeth. So they were just extra, like a supernumerary, like an extra tooth, and that they always needed to be removed. And they're hanging there, and everybody's losing their mind, and on the floor with the nursery, and they're trying to nurse, they're trying to feed, and they're like, oh, this baby is going to swallow this tooth. They're going to aspirate this tooth. So we need this pediatric dentist to come in and remove this tooth. So that was my job. So I did it twice in residency, and everybody's staring at you, the mom, and there is no forceps to take out the tiniest little teeniest thing,
Little nub.
yeah. And so they're like, here's a hemostat. So it's like, all right. And so there's this baby in my lap, and I go to pluck it out, and you pluck and you pluck, and you're like pulling. This thing didn't want to come out at all. And so you'd have to kind of turn it. I mean, it was really in there. So they're never going to fall out. That's number one. And then number two, unfortunately, we figured out through studies that a lot of times that is, most of the time, 99% of the time, that is actually the baby tooth.
The baby tooth.
And so you don't want to extract that tooth. And they've actually figured out that a lot of times if you do extract that tooth, that you're also pulling the tooth bud for the permanent tooth.
Oh.
And so many of the kids that had that tooth removed at birth had no permanent tooth.
Wow.
Mm-hmm.
Yeah. So I've never seen it. I've always heard about it.
So I feel bad that I did it, but
Yeah.
that was the research came out while I was a resident, so it changed.
Yes.
So partway through, we were like, no, we don't remove the tooth anymore.
And that's one of the things about medicine. When I started medical school, the first day of school, you're going to learn 10,000 new vocabulary words, and half of what you've learned in medical school will be obsolete within 10 years.
Absolutely.
Right.
Yeah.
It's always changing, and the thought is changing, and the belief system is changing.
Yeah.
And so there's nothing absolute. So, people get stuck in, this is the way it has to be. But no, things are always evolving.
Absolutely.
And I can only imagine in the Middle Ages, if a baby was born with a tooth, what kind of lore and superstition would have happened around that baby.
So there's Shakespeare. Shakespeare has in one of his writings about like it's a curse that a baby is born with a tooth. So it's been going on for that long. Yeah.
Right. Okay. No, some just more practical questions for a parent. The baby bites into their lip or bites into their tongue.
Okay.
My understanding is if it's not through and through, then the mucosa will heal itself. Is that
absolutely?
Yeah. So, okay.
So I don't think a lot of oral surgeons are even suturing for wisdom tooth removal anymore. Oh. So we're just realizing that the human body will will on a child especially, or a young person, will heal itself pretty easily.
And the mucosa heals super fast.
Oh yeah,
It's crazy.
oh
I
yeah.
mean, like
By the time
10
you get the
times.
things out to do it, it's like, oh, it's
Almost
already,
like a sci-fi movie.
Yes.
It's almost like, you see the alien get cut and then and everything goes back together. I mean, the mucosa will heal that fast. It's like, I'll tell parents, they bit their tongue, and I'll say, in 3 days, it'll turn white, and then within 2 or 3 days, you won't even know that the child bit themselves.
I had a kid one time, it was like my first week as a dentist. I walked him to the front, the kid was numb, and the parent was brokering the next appointment. And the kid walks over and hands me something. And I look down, I'm like, what is that? It was a piece of his tongue.
Oh,
he
wow.
bit a whole piece where it was numb and just handed it to me. So I'm like,
Was he bleeding?
Oh, yeah. But, and I'm like, oh, no, what do we do? So I was an associate, so I get the senior dentist, and he was like, it'll heal up.
Yeah.
So we saw him back, and a week later, and
did it regrow?
Like,
or
it
you
just healed right up.
So it's what regenerated, kind of like a liver would regenerate if they're small enough.
Just kind of pushed together and healed up.
Wow, no divot. There was no divot.
It
just
was fine.
rounded out and smooth
Isn't
and
that
contoured.
crazy?
Wow.
Yeah.
That's
That's
amazing.
pretty crazy.
Yeah, that is. So we were also taught, and remember Dr. Benjamin, I refer to him a lot. He was my professor in community pediatrics, general pediatrics. He went to Harvard, practiced pediatrics for 30 years, and then decided to finish his career doing academics. And he said, when a grandmother asks a question, you better know the answer, because otherwise you don't know anything. And one of the questions they'll ask you is, when is my baby getting teeth? Or how many teeth should they have at a year old? And so he taught us 4 teeth by a year and 1 tooth a month, every month after that, until they have all 20 teeth.
Yeah.
Is that pretty much what you guys?
Pretty much,
Okay.
yeah. So the eruption of the first tooth is supposed to happen at 6 months of age. And so anything 6 months in either direction is within normal, is what I was always taught. So birth would still be normal, and a year old would still be normal. So
as long as averaging, 4 teeth by year. Now, are the baby teeth different constitutionally than adult teeth, other than size and obviously the timing of the tooth coming through? But are they essentially the same material, the enamel and the pulp?
Yeah, they just have bigger pulps.
Baby teeth have bigger pulps.
And so when people say, oh, it's just a baby tooth, it's got a little cavity, what does it matter? Well, if that cavity was in a permanent tooth, it would take, if this was the tooth, the pulp is so big that it only takes a small amount of time to get to the pulp, versus a permanent tooth has a pulp that's really protected. So you could have a cavity for years, and it slowly gets to the inner part of the tooth, if that makes sense.
Yeah, it does. There's much more, you have to dig deeper to get to the pulp.
Yeah. So they're more at risk. I mean, you don't have as much time to wait to treat the tooth. And so it's kind of like, well, we can watch and see, but sometimes, I can look at a tooth and say, you have this much time, or you have this much time for this. And they think I'm crazy, but it's usually, within a year. Yeah.
Yeah. Now, is the enamel around the pulp, how porous is it? It's like concrete.
Pretty strong. Yeah, it's pretty strong. Yeah.
And I shouldn't say porous. How permeable might be a better, because what I'm trying to get to, my question is going to be, why does a baby tooth have such a larger pulp? And what comes to my mind is that the nerve in the pulp is trying to gather information from food that's coming into the mouth, or I'm trying to look for more of a reason than that's just the way it is.
I don't know. That's a good question. Yeah, I don't know. I didn't think about reasoning why. The only thing is just the fact that it is more, the pulp is more of kind of a hollow area, and that's how the permanent teeth know where to erupt. And so they follow path of least resistance, which would be more of a hollowed area versus hard bone. That's why you don't see teeth just popping in everywhere. They'll pop in, they'll follow that root. The root will resorb, and then the permanent tooth knows where to come in.
Okay.
It's its guide.
So that would be a guide on the, but I do wonder why, because children, aren't, the oral hygiene in kids are really not that, it's not, from an evolutionary standpoint, you would think that an adult would have a larger pulp just because we take care of our
Pulps
teeth.
get smaller as you age. So if you work on an 80-year-old and you want to do a root canal, good luck finding the actual canal. Over time, the teeth, with the pounding and the pressure, the pulp resorbs.
Mm-hmm.
Yeah.
Okay. And now, when you mentioned root resorption, so I'm going to jump forward now.
Okay.
Okay. The root with orthodontics. Some people will say, well, my roots resorb because my teeth were moved too quickly by orthodontic appliances. And then other people say, no, that doesn't happen. You can't cause absorption, reabsorption from moving teeth, even if you do it rapidly. What is there a current thought on that?
You absolutely can. I think every person that does orthodontics knows that that's a possibility. It's a risk. Some of it is forces applied quickly. Sometimes it's the amount of movement that the tooth needs, and it's just a lot of movement. Sometimes it's just happenstance. It's just genetics. They don't know why. Some people will be more, you can do everything. Just like every other body part, you can do everything exactly perfectly, and you get a different result than the last time. And why did this time turn out this way? And there's a lot of studies on root resorption. It's mainly slower forces are applied are going to prevent that resorption. That's the consensus
that would
right
make
now.
sense. Right. And then there's other factors because we, there's strain patterns that we hold in our bodies. And so why is it one person's knee starts to ache as they get older? Is because there's a strain pattern, the myofascial tension lines that we accumulate over our lifetime because of how we hold our bodies, or maybe we got in a car accident or we fell off our bike or we tripped on, and then you get trauma in your body, and there's an energy point that enters the body from getting punched or falling and hitting your knee or something like that. And unless that energy gets pushed back out of the body, it's going to be stored in the body, and then you're going to create a tension line on that, and that's why we get ropey muscles. And so I'm just wondering, for those individuals that are having root resorption, that maybe there's a tension coming through the scaling muscles, or they keep their chest in, but this is more of a kind of a holistic perspective.
Yeah, I'm trying to. You're going to have more relapse. So the idea of where the teeth are in the mouth is starting to change. So it used to be more of a genetic. You genetically you just look like your dad or you look like your mom. That's why your teeth are crooked. Now the idea is more. Most people are going more toward the function of your muscles are what are actually making your teeth crowded and crooked. And so your breathing, your tension in your neck, how you eat, how you swallow, all those things can actually contribute to how you look, your facial aesthetics, the length of your face, the growth and development of your jaw, things like that.
From just the muscles.
Yeah.
Well, that makes sense.
I personally think the muscles rule. The muscles are the key.
They're acting all the time. Like, we're not chewing all the time, but we can clench our teeth a lot, and then that's going to change, get larger masseter muscles on the sides. And
yeah, exactly. Yeah.
Now, a couple more questions on orthodontics. I'm seeing more and more of my patients use functional orthodontics or the myo braces, and they approach orthodontics from a more, as I understand it, they approached orthodontics from a more a neck up anatomical. So they'll take a picture and they'll look at certain measurements between your cervical spine and the angles in the jaw, and I don't know all the areas, but they'll make measurements. And as opposed to an orthodontist, again, very rough sketching.
Yeah.
Just looking at the cosmetic aspect of where the teeth are positioned.
Okay.
I had orthodontics, and I don't remember anybody making measurements of my cervical spine.
Yeah.
But then I'm seeing my patients now coming with these myo braces and retainers that have been made specifically to move the jaw around or shift the teeth bite. And
So traditionally, you probably did have a measurements. You just didn't realize that they did those. Orthodontists have been doing cephalometric X-rays, which is like an X-ray going this way, and they pit a lot of the information off Sella turcica and plot and plan, and they have longitudinal studies from like the 60s on Caucasians, and then they've added in different races of what normal would be. And so that was a lot of times how orthodontics was planned from those tracings and growth predictions. I feel like people are going away from that a bit and going more toward the muscular and the airway aspect of planning and doing more of an aesthetic, like almost the thought pattern is not to go to norm, but to go to tongue size and to go to functional standpoints for the muscles and for breathing, and more specific toward myofunctional therapy and speech therapy and things like that.
Yeah.
Yeah.
That makes it moving away from just an anatomical definition
Yes.
into more of a functional
And
definition.
more away from just specific skeletal to more of a whole face approach.
Yeah, because what do we use our mouth for? To breathe, to speak, to swallow.
Exactly.
Yeah. And then we're looking at that as a driver as opposed to just some arbitrary, well, not an arbitrary measurement, but just some kind of.
Yes, we don't all fit into an exact box. Yes,
right.
Exactly.
With wisdom teeth,
Mm-hmm.
Why is it the kids have to have wisdom teeth? Did we have larger oral cavities 100, 200, 500 years ago?
That is the thought that, and you can read so many different things on this, but that our breathing was different, our exercise was different, that we had bigger faces, we didn't have, our jaws weren't as retruded, and that those teeth would fit. I think you can find arguments in either direction. Basically, there's a push now, keep your wisdom teeth. Great if you have space for them. If they're partially erupted, then they're going to be half under the tissue and half in the mouth. And eventually that's going to catch up with you with either cavities or infection from food packing underneath the tissue. So that's kind of a no-go. The other aspect is if they're never going to erupt in the mouth, if they're sideways, if they're going to affect the tooth in front of it, get ahead of it, get it over with. Don't wait till you're 40 or 50 and your bone is hard and they could break your jaw when they're trying to remove them. You want to do it when it's smaller, when the nerve damage is less of a potential. So your dentist can usually look at that and give you an idea like, hey, you can wear your wisdom teeth or you're definitely not going to be able to wear those wisdom teeth.
Yeah. And when I had my wisdom teeth taken out, my general dentist, the dentist that I went to for my whole life, took them out. Is that, now I see my kids all went to an endodontist, is that the right?
Oral surgeon.
Oral surgeon.
Yeah.
They went to an oral surgeon. Is that just kind of everybody's becoming more specialized?
Everybody's different. Yeah. So, anybody that does something all day long is going to be quick and efficient at it. And most people want to be sedated now. They don't want to be awake. I was awake when I had my wisdom teeth out.
Yeah.
And mine were impacted, but I was awake and I was fine.
Yeah, just a different time.
But, I don't think that a lot of the kids today want to be awake for that. So most people don't. So we have that. It's quick. It's easy. So I think that's where, some of that comes from. Yeah.
And why is it sometimes they have to take out the uppers and not the lowers, or lowers and not the uppers? Is it just the space that's available?
So basically you're going to take out both. You're going to take the uppers and the lowers out because then they won't have teeth to occlude.
Okay.
And if you have a tooth that's not occluding another tooth, then it's going to super erupt and then just kind of hang down and eventually have to be extracted anyway. But sometimes it's timing. So let's say the lowers are really turned sideways, or you need the orthodontic movement needs to push back into that area. You need those teeth to be gone. to do that movement, but the uppers would be very traumatic to get to because they're too high. Then you might do the lowers and then the uppers. Most of the time, the oral surgeon wants to just do all four so that you're under anesthesia once and it's over with. But I've had it come back a couple of times where it's like, it's just too difficult to do the uppers right now. Let's wait on the uppers, but let's definitely get the lowers out.
And when I had my wisdom teeth taken out, so this is 1987, and I remember Dr. Ziegler, he said, well, this one's going to hurt a little bit because he had to go through my hard palate. And I was like, oh, yeah, sure, you know. And he had to do both sides. And I remember I think I ripped whatever the faux leather was off of his chair because I was white-knuckled. That to push through the bone, that was painful. I do remember that. I remember that. Aww. But then the funny story was he had an assistant. I'm 20 years old?
Yeah.
I'm 20 years old. It's summer between my sophomore and junior year of college. And he had a dental assistant, pretty young lady. Mm-hmm. So, and again, Ziegler I'd known my whole life. And he would be at family parties, so I knew him really well. And so afterwards, I'm just chatting it up with her. But I have no sensation on my face. But I can speak, at least normally. It hadn't set in enough because later I couldn't speak at all. It just, I didn't have any. But at this point, I could still talk. And he's down the hall, and he's just smiling at me. And I'm here, the lady's here, and then he's down here. And he just goes like this. And so I just reached my hand up, and then I realized, because I was numb, I had spit and blood hanging down. So I'm trying to lay a wrap on this chick. And she's just being polite, just talking to me. I'm looking like a total bozo. So I remember that. That's funny. Dentist fun. Let's talk about amalgams versus what what are they doing? Porcelain or composites, or what do they call it now?
Composite would be the equivalent to the amalgam. Yeah. Composite resin. So there's people still doing amalgam out there. I mean, a few years ago, there was a doc in town I know that did amalgam. Amalgam has mercury, but once it's set, it's not supposed to be emitting the mercury. Now, I have one amalgam, don't tell anybody, and I like it. I like it where it is. I don't want it removed because I know when they remove it, it's going to actually plume the mercury. So I would rather have it be stable in there. Used to the composite resin restorations just weren't there. So like in the when I was in dental school in the 90s, we were told, you do the white fillings on the front teeth, but do the amalgam on the back because they always fail on the back teeth. And that was true. But now the resin restorations are amazing. There's no reason to do amalgam restorations because the resin is a superior product. And so that's why you see a lot of people that have the amalgams, because up until like the early 2000s, it was just a better product. And I realize there's people taking them out for health, but the consensus, I think, still is that as long as it's set, you're at a lower risk. Would you want to put a new one in now? No. But if you have them, I would leave them. So I had amalgams. I had to take them out, and I had the composites put in. Yeah. And they did the high suction because I was concerned about that. I said I would rather keep them in and not have the plume of the mercury. Yeah. And he said no. And they had this super duper equipment in my mouth, and it was high tech. So I had them taken out. And then I had the composites put in. What I don't know if it's a criticism. One of the notations, I guess would be a better way, was when the argument was, well, we put the amalgams in with the mercury, and then it sets, and your body will reach a homeostasis where if there's any leaching out of the mercury from the amalgam into your body, that's already happened. And once the amalgam is set, then it's not, your body's in homeostasis with the mercury that's already leached out. So, but then in the functional world where people will clear mercury or heavy metals out of their body, that'll create the osmotic difference again. And then there could be leaching out. This is what I've heard in the functional world. And then, so if you do some kind of a DMSA or an EDTA to clear metals out of your body,
then there's a void of metal, and then the mercury will come back out of the tooth. Again, I'm not expecting you to know the answer,
Yeah, I'm
but
not
this
an
is just,
expert on that. Luckily, as a pediatric dentist, I have basically I have a fresh tooth.
right.
I'm not in a general practice. You're constantly removing restorations, putting new restorations in, and I kind of get fresh teeth on.
Yeah, nice.
Yeah, it's
Yeah.
really nice.
Yes,
Yeah. So that's not been something I've had to really deal with. But I know there's a lot of people out there that have all the equipment and everything when they remove the amalgam for sure.
Yeah, like the fresh teeth, the new teeth. I'll tell parents, they'll come in, I think my child has a bronchitis. And I'm like, kids really don't get bronchitis very often. It's kind of very unusual to diagnose bronchitis. And again, think of them like your new car. Like there's not often a problem with your new car. And kids, new teeth, young lungs, very resilient. Most likely it's not, going to have issues like that. So
Yeah.
I refer to babies and small kids as new cars, and there's not usually a problem with new cars.
True.
Yeah,
Yeah.
very true. So when should a child baby, toddler, first go to their first dental appointment?
Okay. First birthday, first visit is the new recommendation from the American Academy of Pediatric Dentistry. Why? There's a lot of things that we can talk about in that first visit. It's sometimes more of a conversation than an actual procedure. So we'll go over brushing techniques. We'll go over pacifier. We'll go over feeding, eating, a lot of things like that flossing, things for the future. We'll do the examination. We'll check for cavities, obviously. We'll look at the mouth for structural issues, and then we'll see that patient every 6 months, and they have a dental home. And if they have a trauma, their first visit to the dentist is not that trauma visit, and they are used to the place. Oh yeah, remember we went there. I got this toy and this or that, and then it's not a scary place. Kind of like you take a kid to they take kindergartners to the fire station to see the fireman in his uniform and in the what do you call it, when they go into the house, so that if there was a fire they wouldn't be scared. So it's kind of the same thing. It's a little desensitization to come in, lay in the chair, see what's going on.
Yeah, I was aware that the American Academy of Pediatrics recommends at 1 year old. My experience is that most parents don't. I tell them wait until 2, just because there's generally nothing much to do at that point. But you raised some good reasons to go, and I always feel that you guys would be, the pediatric dentist, would be inundated with all these 1 year olds that don't really need a lot of care. Maybe I'm making an assumption, but you do encourage. I should change my practice style.
Yeah, well, it's fun because you usually get the mom and the dad, and they're so nervous. And then you bring them in, you talk in kind of a room like this, and you go over any concerns, that's the point where they're like, do I get off the bottle? What do you think about this? A pediatrician told me this, and then I kind of will have your back on a lot of those things and give another aspect, another reason, 2 people saying the same thing. And then, kind of go through a guidance of those kind of things. They're worried about thumb and finger sucking and pacifier and what do I do here? And I can give them, instead of saying, okay, you need to be done with this today, I can say, okay, you're okay with this now, plan this for this time. And they don't have everything kind of all at once. And it gives a little more of a longer plan for those things.
Spacing it out so it doesn't seem as overwhelming.
Yeah.
So I tell babies, toddlers have a need to put things in their mouth. Everything goes to the mouth until about 15 months old. And you don't say a lot of words, because if you're putting things in your mouth, you're not really functionally designed to say words. So there's very little word development until after 15 months old. So I'll tell parents with thumbs, pacifiers, I always tell them thumbs are nice at the start of life because the kid can find their thumb. Whereas the pacifier falls out of their mouth and they don't have the ability to find things in their crib. And so you're constantly all night long putting the pacifier back in. So thumbs are nice because they can find them early, but the problem with the thumb is you can't take them away later.
Yeah, the child owns the thumb.
They own the thumb,
You
right?
own the pacifier.
Right.
Yeah.
And so I say you're going to front load or back load your problem. So if you're going to front load your problem, then you do the pacifier, and then whenever it falls out of the baby's mouth every hour or whatever that is, and they start crying, you have to go walk into the room and put it back in their mouth. But then you can take it away after 15 months. And I say 15 months because the baby has that oral need, and so I don't really take it away because if a baby is by developmental milestone has an oral fixation, I don't want to take something away that is been designed much higher than my medical degree allows me to understand. So I'm like, okay, go ahead and use it. After 15 months, then I'll say, okay, well, let's really limit this down because they don't have an oral suck swallow need anymore. And then let's just limit it to falling asleep, pull it out of their mouth when you walk by. Obviously, thumbs I can't do anything about. And then if they really are attached to it, I tell them to take the pacifier and tie it to a door handle and with a very short string because we don't want to get the string around their neck. And then you turn the pacifier into a commodity because when I look at parenting approaches, I don't want the child to start to see that the parents will make you do things because the child doesn't understand that the parent's doing something to them that's in their best interest. The child only sees these big people make me do things, so when I get bigger, I'm going to make them do things. And that's how we get into these 4-year-olds that have a lot of behavioral issues because they're only really mirroring the parents who've just made them do things. Anyways, that's the pediatric side. So I tell them to turn the pacifier into a commodity so they can go and play with their toy on this side of the room, or they can walk over and suck on their pacifier and not play with their toy. So then you're not taking it away. Now you're just structurally limiting their access. I'm just curious on your thoughts on that.
Yeah. So, what I've been diving deep into is why does one person desire that non-nutritive suck versus another baby or another child, and why does it go beyond a certain age? And it's starting to come back to the muscles. If the tongue is not in the proper place in the mouth, then because the tongue basically controls the self-soothe, and it lays back there and soothes on the vagus nerve, and so that suck is a way to create suction on the vagus nerve, to create that self-soothe, to decrease respiration. So it's kind of a crutch for something that should have been an innate, like a self-soothe that you could do on your own. So why are we at that point? Why do we need that beyond one? Why do we need that soothing? Is there a tongue positioning issue? Is there a swallow issue? Is there a breathing issue? What's going on with that? And so should we do myofunctional therapy? Should we look at tethered tissues? Should we go into why and why do you need that beyond the normal? And so that's where a lot of the newest stuff is coming out, and so I've been diving into that, and I don't hate pacifiers. I love pacifiers over a thumb. I can't get rid of a thumb. I've seen kids sucking their thumb at 12 years old, and you can't get rid of the thumb. The pacifier you own as a parent, you can eventually get rid of the pacifier. You have to understand, why do they need that self-soothe? If there's a brand new baby, if there's, you don't want to take that away at that point.
Right.
You've got to pick a good moment, and then you also have to look at the structures in the mouth and decide, do we need therapy first? And we've got some myofunctional therapists that do thumb sucking cessation programs, pacifier discontinuation programs, but they're also looking at the structure of the face to decide, is it a good time? So it's an interesting. That's a deep topic, right?
No,
now.
I always like looking at form and function, and that it does make sense. Sucking on a thumb or sucking on a pacifier, then it stimulates the vagus nerve, which then calms you down because the vagus nerve is part of your parasympathetic system. Then it made me think that chiropractic care may be a benefit for when you have overriding sutures, and then that can compress the vagus nerve, which then can cause overstimulation, which leads to reflux and GI issues like bad constipation or irritable bowel or just colic or things like that. So yeah, that is benefit. I just learned something. That's good.
Oh, well, finally, I
Yeah.
taught you something. Yeah. Also, they're starting to recommend expanding the palate and that it'll deprogram. So used to, I always said we have to get rid of the thumb or the pacifier habit first before we expand the palate. And literally this week, I'm reading all this stuff saying, no, go on and expand the palate and it will deprogram the need for the thumb. And I'm like, okay, like that feels crazy, but that's on my list to do.
Right. Yeah, I mean, it's a chicken or an egg, really.
Yeah.
Yeah, chicken and egg. Now, I just want to say that I think some kids will suck their thumb or take a pacifier because the home environment is a little stressful.
Yeah,
So
yeah,
so there
yeah.
can be that component.
New
which
babies,
then
new baby,
conflicted marital
move,
environment.
in divorce,
Yeah.
yeah, absolutely. Yeah, they get to take with them, or their thumb gets to go with them, and so
Yeah.
you kind of have to look at the whole thing and say, is this a good time? You don't want to potty train. Get rid of the bottle, get rid of the pacifier, everything all
Send them to
on the
nursery
same
school
week.
all at the same time.
Yeah, same week. Okay, yeah.
And grandma was living with us, is now
Yeah, now
moving out.
she's
Yeah, that's
gone,
yeah.
yeah,
No, we
yeah.
have to look at the whole child and their environment. And
Absolutely.
so you mentioned the palate expanders. I'm seeing a lot more of that. I mean, let's first talk about, so when you're taking a thumb or you're taking a pacifier, there's a vector, which is a force with direction. And so when I'm sucking on my thumb, I'm pushing a force up this way, and then a baby toddler's growing. So then the palatal arch will vault,
Correct.
cathedral,
Yeah.
and then that narrows the maxillary arch. And then now you got a narrower bridge or arch. And then that makes it difficult for the tongue to come
Yeah.
up.
It's like a cycle. Yeah.
And
Yeah.
so more and more kids are sucking the thumb. Is there anything, again, I might be reaching a little bit, and I'm borrowing a little bit from Weston Price, who was a dentist. Do you know who he was?
No, I don't.
So we learned about him in medical school.
Okay.
He was a dentist in the late 1800s, early 1900s. And it was common at the time, he went sort of traveling around the world to look at dental health in different populations in the early 1900s. And he noticed that indigenous cultures who ate whole foods had perfect teeth. They obviously, in the middle of
Yes.
New Guinea, Papua New Guinea, they don't have the local orthodontist.
Mm-hmm.
But they all had perfect teeth. Everybody in the tribe had perfect teeth. And he attributed it to real foods eaten in an appropriate balance of different nutrients, not just like, oh, soy is good, let me eat a lot of soy. But the Japanese eat soy in a certain proportion with other foods. And so soy has been taken out of context, and everybody's like, oh, soy is great for you. But no, it's part of a larger picture. So his work focused on, and he has a foundation now, which he's passed many years ago. Now he has the Weston Price Foundation, which focuses on whole foods as the primary way to stay healthy and maintain health. So do you think that some of this vaulting of the palatal arch
Absolutely.
is because of the diet?
Yeah. We Western culture, soft pureed foods. This idea of baby food is kind of a newer concept, and so we're not using our. So start from the beginning. So if you breastfeed, the child learns to use the tongue correctly. Has to kind of work for the food. You take a bottle and they just the milk, and so there's no finesse to that. The jaw doesn't need to work. We don't learn proper movements of our tongue. Then after that, we're gonna move on to this mushy food, and we're just gonna go baby food for like a year, and it's just mush. We don't learn to chew or eat. And so I think it just comes back to the muscles aren't used appropriately.
This is going to be a cool part of the talk here. So I tell parents, like, I am not a fan of baby-led weaning. Do you know what baby-led weaning is?
No.
So
Okay.
well, let me back up. I'll do the pediatric side for a bit. So I tell parents not to start food until 6 months old because the GI tract is not fully matured until 6 months old. I mean, there's some pediatric GI doctors and pediatric allergists that are saying start high allergy potential foods like peanuts before 6 months to capitalize on the developing immune system around the gut because there's higher tolerance during that period. So in my opinion, what they're doing is what we do with grandma. Oh, you have a poor lifestyle, so you need high blood pressure medicine. So we're going to give you, whatever high blood pressure medicine. Oh, that medicine's causing a problem with your potassium levels. So now we're going to give
something
you
else.
Right,
Yeah.
right. So to me, what the allergist and what the peds GI doctors are doing is, well, let's start peanuts early because, kids are being born by C-section. They're born, mom has group B strep, so she get antibiotics. And now the kid, is having GI issues and now is more prone to having an ear infection. Now they get their own antibiotic. And so this is leading to a lot of inflammation in the gut, which historically wasn't there. And now we're seeing a rise in food allergies as a result of, and vaccines, I got to throw vaccines in there. And now we're seeing a rise in food allergies. So now we're going to play with our organ system development before it's ready by introducing topical. So to me, it's just like giving grandma a second medicine because the first medicine caused a side effect.
Yeah.
But anyways, so at 6 months, I start with pureed foods. But by 9 months old, I tell them, so, at first they've only drank liquid. And I'm interested in your kind of dental opinion.
Okay.
They've only drank liquid up to that point. So that, we don't go from liquid to let me take a piece of steak.
Yeah,
right?
yeah.
No, that's choking. So we start with mushy foods, and then over the 6 months to 9 month period, 3 month period, they will then move to, now they have pincher grasp at 9 months old, so they can put discrete pieces of food in their mouth. So we gradually increase the chunkiness of the pureed food to the point that at 9 months old, they could pick up a piece of food and put it in their mouth. So I don't do mush food out for a very long time. Now, by 15 months, they should be on all table foods. By 12 months, they should be on when I say table foods, I mean our food torn into small pieces.
Right, yeah.
12 months old, half of their food should be our food torn into small pieces. And they might still do one of those like squeeze, like applesauce things and stuff like that. But I progress them over from 6 months until by 15 months they're on all table foods. So over a 9 month period, they just increase the size of the food particles. As opposed to baby-led weaning, which is, here, let me give you a boiled carrot and you're just going to manhandle that and just stick it in your mouth and eat however much you want, which to me is a total choking risk. Or you give them a rib, like a pork rib or a beef rib, and they're just sitting there gnawing on it. To me, that's dangerous.
Yeah, I think so too. Yeah,
okay,
for
good,
sure.
good. Because I get into arguments with these baby-led weaning people, and they'll be like, and they'll cite some research. And the first time I got in an argument, I was like, oh, I didn't know that research. So I went and pulled the article while I was in discussion with this person. And I said, but you didn't include the back half of the conclusion, which was, yes, it can improve fine motor skills. It improves, hand-eye coordination, spatial relationships. And the food should be designed to fit in the mouth and not be chokeable. But the next paragraph says, anybody that's doing this should be trained in CPR. You're not telling that part. Because if you're giving your baby a piece of food that can go down their throat, you should 100% be trained in CPR. But it's not as easy being trained in CPR because you know how many years it took me to be comfortable to resuscitate a baby? Because when you walk into a room and you have a kid in code, you get sweaty, your palms get sweaty because you realize I am the only thing that's standing between this kid and their death. And you freak out. Now imagine that was your own kid and you don't have 3 years or 7 years of training. You're going to lose your mind.
Right.
Yeah. So to me, baby-led weaning is complete.
Yeah, I don't agree with
It's
that.
a disaster
Sure.
at all times. It's like, let my baby walk the cliff so they can learn balance. Okay. Yeah. No, thank you. All right. So going back to good, we agree on that one. The starting food at 6 months old. Now, when you say mush food, then you said 12 months of mush food. So just so we can clarify for the moms listening, a progression out to particulate matter in that rapid 3 month.
I think my personal view is that in America, what is marketed toward babies is very high sugar.
Yes.
Going to cause a lot of dental cavities. Some of the things that you just think are, because they just keep telling you like this is good. The TV tells you this is a great product. This is a good product. It's like it's yogurt, but it's more sugar than yogurt.
Right.
So I think Here in Naples, I think we have a lot of very educated parents that can see through some of that marketing and some of the uh, fluff with what's for a baby, what's not. It's better to make your own food, make your own dinner, and then give give the child some of that. Look at a whole meal, but I think if you were to solely say, okay, what does TV tell me? What does the internet tell me to feed my child? Sometimes you're going to be really overwhelmed with really high calorie, low quality food. Let's look at apple juice. Apple juice is disgusting. I mean, if you look, there's been apple juice that's had how many like times the recommended amount of fluoride in it. They've had arsenic in it. Apple juice has just been a horrific product. And a lot of people do a lot of apple juice because, oh, baby's constipated. Well, why is baby constipated? Because baby didn't eat any actual fruit or any whole foods that with fiber. So now you're trying to clear everything out with apple juice. Now baby has a ton of cavities because they drink apple juice. Now baby's obese because they drink tons of apple juice. So I feel like from a consumer standpoint, you're told that this is what you're supposed to feed your child. You're told in the grocery store with pictures of babies that look your
Little
baby's
Gerber baby
age.
and
Yeah, and so you've got to step back and say, what did my grandmother do? What did we do when we lived on farms? Like what was more natural? So
yeah. So it definitely is. I like the idea that we're looking at the muscle development to help bring along proper nutrition and mouth shape, mouth function.
Yeah.
Now, is there a point from a dentist standpoint that a baby should stop nursing? Is there something that goes on for, the quality of the breast milk decreases at 12 months old? Because at that point, they can eat their fat, carbs, and proteins from solid food sources. So the importance of, the superfood breast milk is less important as a nutritional vehicle because they can get fat, carbs, and proteins from regular food.
Yeah.
And I tell that to moms. I said, if you enjoy doing it, continue. If the baby wants to stop, you want to stop, then go ahead and feel free to stop. But is there something from a baby continuing to take a breast?
Yeah, dentally, you can get cavities from breast milk very easily. And so I love breastfeeding. I love the fact that it trains the jaw. It creates a better swallow. It's a wonderful product, for the baby to ingest, but it does have a lot of sugar. And so when you breastfeed or you bottle feed, that sugar is going to lay on the back of the front teeth. And so it's a very telltale early childhood caries development to get cavities on the back of the front teeth. So it's kind of like a tree that you would chop from the back, but if you stood on one side, they look beautiful, but from the back, they've been chopped or they have cavity. The teeth would have cavity, and they're very thin. They're sometimes nobody knows that there's a cavity on that tooth until there's an innocent fall and the tooth breaks because there was just a little rim of the front white part of the tooth left. And then they come to me and I take a mirror and I turn the mirror upside down and I look and I'm like, oh, there's cavity on all the teeth. I'm like, how did I know? And that can happen with nursing. It can happen with bottles. So I don't care if you nurse for a very long time. That does not bother me. But you do need to clean the mouth after any liquid other than water. So you can't, what I find is that after nursing, the breast milk is no longer a real food for them and it's more of a comfort. Sometimes we're doing a co-sleep and then it's kind of like a pacifier through the night. That little bit of breast milk all night long will cause a lot of cavities. So I'll say, okay, continue to breastfeed, but the last thing in the mouth needs to be a toothbrush, water. If you're going to breastfeed to fall asleep, then you're going to have to find a way to clean the mouth afterwards while the baby's asleep. That becomes a little bit of a hassle. But I've seen a few people get away with it, and they end up with no cavities, and they're breastfeeding until 4 or 5, but not usually.
Right,
Yeah,
right.
usually it catches up with you and becomes a real problem.
Yeah, I mean, I don't know, some people, once you see milk carry rot,
Yeah.
it looks like a meth mouth. It looks like somebody that's been addicted to meth. And I mean, it really, I mean, it was just like a meth mouth in a baby.
Yeah.
And I mean, they're just like little brown nubs of teeth
Yeah.
coming through the gums, and
It's
they're just
sad.
worn all the way down.
Mhm.
And all those teeth have to get pulled.
Mhm.
Is that
Sometimes.
sometimes? Yeah. And so, and I tell parents, it's like, whether it's a bottle, and you see the kids that bite the nipple on their bottle and they just walk around with it all the time, and they have milk in it, and they're just dripping sugar. It's an IV drip of sugar just right onto the teeth, and that, especially if you had that vaulted arch, I mean the vaulted palate, and now you're mouth breathing, so now you're giving air, which is food for the bacteria that cause cavities, and you're giving sugar, so you're basically creating the best petri dish for cavities that you possibly can. Yeah.
For sure.
So you mentioned cleaning teeth. When do you start? Is it when the first tooth appears? First tooth. And can you just take a cloth in the bathtub and just wipe it with a cloth?
You can do that. I think once the top teeth start to come in, you really should start using a baby
soft
toothbrush. And all toothbrushes should be soft toothbrushes. And you should at least, they've done studies which toothpaste works the best. And the control was a toothbrush with just water, and it actually debrided the teeth the same as any. So the toothbrush is the key, and I think just touching every tooth with the toothbrush and trying to find a way. I get that question a lot. My baby doesn't want to brush their teeth. They don't like it. And I'm like, okay, so let's look at it like this. Your baby probably didn't care to have its diaper changed when it was like a little baby, right? No, just laid there, right? Then all of a sudden one day, this baby has an opinion and wants to roll around. And you're like, baby, you can't not have your diaper changed. You have to be clean because you're going to get a rash. So, you find a way, you work with it, and, and every few months there's a different thing. Oh, they want to roll, or they want to get up, or now they'll lay. And toothbrushing is the same thing. You've just got to get it done. Best brush needs to be at night before you go to bed. And you've just got to find your way, because you can't leave the plaque on there because you're going to get cavities. So you can't leave a dirty diaper because you're going to get a rash. You can't leave the mouth dirty. You're going to get cavities. So if you think of it like that, it just has to be done. And your baby is not going to hate you, and they're not going to never want to brush their teeth or never go to the dentist. And, it's great to do fun things, but sometimes nighttime just gets tiresome, and it doesn't have to be a 2-minute brush. It just, you need to get in there and just touch every tooth and then be done.
Be done. Yeah. And that speaks to a much larger parenting issue that I see, which is instead of parenting to build confidence or parenting to the child's long-term interest, a lot of parents are collapsing into this, I'm parenting to comfort, and they don't want to stress their child out, as if any distress from the child is so problematic that it overshadows their long-term health interest. And it's very common. I mean, I just had a family in the practice, in the office today, and we were talking about what we have to do as parents to prepare them for adulthood. And University of Michigan Mott's Children's Hospital asked parents of 17-year-olds, have you prepared your child for adulthood? And this speaks to what you're saying. 87% of the parents patted themselves on the back, said, oh yeah, our kids are ready for adulthood. So then they went to the 17-year-olds. Can you read the back of an over-the-counter medicine bottle like Motrin or Tylenol or Benadryl and dose it? 8% of 17-year-olds could read the back of a medicine and dose it correctly. 25% knew how to wash a car. 25% would be able to pick up the phone and call you or me to make an appointment at 17 years old, because the parents are doing everything. They've comfort parented. They haven't prepared their child for long-term interest. They've only made themselves feel good. And that's unfortunately, that's my uphill battle as a pediatrician, is to help parents realize that your job is not to be their friend, not to make life so easy that they don't know how to become adults.
Yeah.
That, we really want to stop and look at what a child is able to do as they gain their different milestones, and then honor them by saying, just like you would want, if you went to your first pediatric dentist office and they said, well, you just have to answer phones for 2 years. You're like, no, I'm out. Because they're not honoring you with what you're capable of doing. I've earned this right. I can do this. Baby's able to sleep through the night because of the circadian rhythm. Well, then, let them sleep through the night, because they wake up and cry in the middle of the night. Doesn't mean that they need attention. They just haven't learned how to sleep through the night. Just because your kid can't ride a two-wheel bike the first time they're on their bike, you're not going to say, well, throw away the bike because it doesn't work for you. You have to sit there and help them with that struggle to learn to master that milestone. And so, unfortunately, that's a huge problem in parenting today, is we're comfort parenting. And then you said one other thing is, they don't want to stress the child out. There's two kinds of stresses I identify to parents. What I did with my kids was, when they got older and they started to push back on brushing, I go, easy way or hard way?
Yeah.
Easy way or hard way? You got two choices. We can do it the hard way, where I'm going to put you in a headlock and I'm going to force this toothbrush into your mouth, or you can just open your mouth. And the first night, they, and they go like that. Okay, hard way, and I force it. Second night, easy way or hard way? Bite on their gums again. Hard way. By the third night, they're like, and then it's all easy, and then we pass through. But that kind of stress that I cause my child isn't a stress that's going to put them on a therapist couch later, because as they get older, they'll be like, yeah, I needed to have my teeth brushed. That was me being immature as a 3-year-old, a 4-year-old that was just trying to take improper control of the situation. And my parents did the right thing. So there's no forward stress with that.
Exactly, yeah.
But if I threw my kid to the ground to make them brush their teeth, and, I did child abuse for 16 years, that's not, it does happen. And, then I kick them, and that's going to be stress that you take later. Right. So you have to.
Yeah, I sometimes think that if I hear parents tell me that they go through 30-minute back and forth, and it takes us 30 minutes to brush his teeth at night. I'm like, that's
giving up power.
Yeah, like that would make me as a parent just like hate the evening. I mean, just get it done and just go do it, like you said, easy way or hard way, and be done with it. Don't go back and forth. Don't do a broker, and kids cause and effect. Sometimes they'll go on and on and on and on.
Yeah.
And and then you're crying, so it's like
so
that.
Stressful.
Don't belabor it. Just
well, you're approaching them when you do that. It'd be like you and I having a conversation. Hey, I really need you to do this. Well, I don't know that I really want to do this. And we'd have a rational conversation about it. But when you're dealing with a 3-year-old who has preoperative thinking and doesn't have a root in any type of logic because they're not developmentally at that point, and you're trying to have a rational conversation, you might as well as be having it with your dog, because it just can't land. But now the kid can recognize that, oh, there's negotiations here. And so, of course, they get a stamp 30 minutes later. They had,
well, that's true. Yeah, you're exactly right.
Yeah. Now that they've had complete control over mom or dad,
they have your attention for 30 minutes. Yeah.
And so they have the win-win-win column going.
Yeah.
And they got 3 sevens across the whatever they call that, the casino machine, the slot machine. Mm-hmm. And you've got a toothbrush in your hand doing nothing. So, yeah.
Except crying,
So, fluoride, non-fluoride toothpaste.
So I am still a fluoride person. I feel like everything is in moderation. There's been journals for one, back, forth. There's a new article that came out April 2026 that is now debunking all of the other articles that were written. This is a large sample fluoride longitudinal study that debunks the idea that it decreases IQ. And so that's been the thing, that fluoride is going to decrease IQ in children. And this came out, I actually brought it because It's so new. It's right here. It's from PNAS, and they just basically said, nope, it's not going to decrease IQ. The other articles, the other journals were done outside of the United States. This was done in Wisconsin. But just like anything, you can have one bad research project, and if that's what you want to pull out and say this is the definitive article, great. But you've got to look at the sample size, how it's done, what country it was done in, who is backing it. So I feel like dentists still love fluoride. What other profession takes a product, tries to get people to use it, a product that would put us out of business? So, the fact that we like fluoride and it puts us out of business is just shows how much we see a difference in people that use fluoride and don't use fluoride. And so I like fluoride. I feel like everything in moderation is the way to go, and it really does strengthen the teeth. They took the fluoride out of the water in Naples, February 2024, and I thought I'm not going to see any changes for a while. And not everybody drinks the water, and they drink bottled water, this that. But about 6 months in, I'm like, whoa, why are all these cavities popping up? Why are all the kids in braces have cavities? Which they had cavities before, but not to this extent. Every kid in braces has at least 1-2 cavities now, whereas they used to, it was like every 5th, 6th kid that finished their braces had 1 cavity. But now it's just different. And so I see a big change with having the fluoride taken out of the water for sure. I thought it would be the babies first, but no, it was the teens.
Okay, that's. I mean, there is when we look at just the tooth, it provides additional protection against cavities. One of the statistics that speaks against the volume of fluoride was that 50% of children in the United States have fluorosis. At least last time I studied that, which was maybe 10 years ago, because I wrote a paper on it. So I don't have any current data, but I know about 10 years ago, 50% of kids had fluorosis, which is too much fluoride. And it was causing the white stains on their teeth. So there was too much fluoride. So was it that the pendulum went too far one direction? Because 50% of kids with fluorosis is not an insignificant number.
So if I remember correctly, basically they were adding the fluoride to the water, but they weren't always checking the fluoride that was in the water at the beginning, and we would end up with some areas that had more than the recommended parts per million. And so areas that have the correct parts per million in the municipal water supply, they weren't seeing that fluorosis. There's places that have 4 times the amount. There were places that, were adding too much. And so it's kind of like, why don't we, instead of taking it completely out of the water, why don't we do better at policing the water, not finding out later that, oh, yeah, it's too much and we added too much. And so I think, again, back to moderation, they used to say 1.0 parts per million. Now they pulled it back to 0.7 parts per million. But that's in municipal water supplies. So it doesn't take into account our kids' free range eating toothpaste. Or they, they put the sodium lauryl sulfate in the toothpaste that makes it foamy and great, but then they're swallowing it. Where are all the sources for it? Yeah.
I was going to ask about, municipal water with fluoride included is one.
It's only one aspect.
Right.
Exactly.
And, we were taught in pediatric residency that it should be a rice grain. Essentially, you should dip the bristles into the toothpaste opening because you only need a very, very small amount because of the amount of fluoride in it. And that's all the toothpaste that you should use, no more than a single rice grain of toothpaste on your toothbrush. And I remember as a kid, it would
Oh yeah.
oh yeah, it would be
yeah,
like the
yeah.
whole
I
thing
need
and
a
a
new
little,
tube,
and the
like
commercial
every
little
week.
had that
Oh,
little like
yeah.
cute little pigtail.
Exactly.
You know, it'd be the whole thing and a cute little, oh yeah, I want to, you know, and you'd be like icy, it'd be like a cupcake, you know?
Yeah.
Yeah. And then if you drink, you know, at least I don't drink canned beverages much anymore. But if you drink one Lipton iced tea, a little can of Lipton iced tea, there was enough fluoride in that for an adult for 3 days. So there's multiple sources of fluoride. So the canned foods, the canned beverages have so much fluoride for the preservation on the lining of the can. So that's where, you know, there's no overall, we can control how many parts per million in the water supply. But again, you know, how chemically driven, you know, inorganic chemistry, when you had that little scale inside of the glass box, so you had no other, you know, no other pressure acting on the weight of the, you know, so you can get a true weight on something. You know, these guys that are doing water management, besides that, you know, they're looking at bazillion other things, you know.
Right.
So you know, you're almost asking the wrong person to be managing parts per million. And then you got it in the food, then you have it in the beverages, and then you have it on the toothpaste. It seems to me that the toothpaste would be the low hanging fruit on all of this, like teaching better toothpaste management.
Yeah, so I always recommend to use a smear. So that comes from the American Academy of Pediatric Dentistry. You know, you use like a pea size for an older child, and then you use a smear for anybody that can't spit. And so that little smear would be like, if the toothpaste is green, you put it on, you look at the brush, you're like, is it even on there? Oh, there it is.
Yeah.
And then you brush with it. You don't rinse it. You actually just wipe it out, and then you get all the benefits on the teeth and none of the risk of the systemic.
Okay.
Yeah.
Yeah.
So that's how I like to recommend it for kids that, you know, now, you know, giving them a tube of toothpaste and they're 6 and they want to eat it. That's a whole other
that's
aspect.
the problem.
Yeah. But
how many parents are watching their 6, 7, 8, 9, 10-year-olds brush their teeth? No, none of them. Do it, brush your teeth, and the kids are like,
yeah. So,
and you can see the globs of toothpaste in the sink from when they over apply the toothpaste.
Yeah,
you know, you can completely see it. Now, you had mentioned earlier, like, that they did a study where they just used water on a toothbrush versus toothpaste.
That's an old study, yeah. And they were just trying to say which toothpaste works the best. And
so do we even need to use toothpaste if the outcome was the same?
So some of it is just this idea that you need that foam, that feeling. It feels fresh. It's maybe a bit commercially driven. So, you know, to debride the teeth, no, not really. No, I mean, you get a little more grit, but if you spent the time, I think the bristles are pretty good. It feels good to have that toothpaste on there. I mean, it doesn't feel right if you don't use toothpaste for me. I mean, you know, but maybe I'm conditioned through, you know, commercial,
You're a victim of advertising.
Absolutely, But
you have a milk mustache while you brush your teeth. Yes.
So but if you're actually gonna, because when you use that toothpaste, then you immediately rinse it off. You're not really getting the effects of the fluoride appropriately, because you just get 2 minutes of it. But if you did a small smear, so sometimes, you know, I'll say brush the teeth and then use like a fluoride rinse, and then that stays on all night, and you actually get the effects of that fluoride.
To me, it sounds like there needs to be a lot more education for families across the country on how much fluoride, where you're getting your fluoride from, which just that kind of information is just.
And we try to talk about it in the office.
I know,
and I think a lot of pediatric dentists tries to do this individual, one person at a time. Yeah.
Yeah, and it needs to be much more mass scale.
That's true.
Because even for me as a pediatrician, I mean, you know, I was always just told rice grain, and you just said no, a pea size, and, you know, smearing, and I didn't know that you were supposed to leave it on all night. I mean, here I am, 26 years in, and 8 kids through the house, and this is all new information for me. No. And so it's just not, you know, it's not you and me as and people. It's the American Academy of Dentistry or the American Academy of Pediatrics. They're just, you know, there's a lot of regulatory and governing body, they spend their money on other things than doing some of the
Yeah,
nuts and bolts.
for sure.
Yeah. Bringing in electric toothbrushes. How old?
Um, it, so a toothbrush is whatever works in your hand. So if somebody comes in and their kid's teeth are spotless and they say, "Doc, should we get an electric toothbrush? Um, I feel like it's time." Da, da, da. And I'm like, what you're doing is beautiful. There's no plaque. There's no buildup. You have no cavities. Everything is great. So, if you want one, great, but you're doing a great job. And then I have other people that I'm like, maybe you need the electric toothbrush with the timer. Maybe you need that extra. You get a lot of buildup of calculus, or what they call tartar, and you need something with a sonic action to it. And so that's kind of the only difference. Now, not all electric toothbrushes are equal. And so Sonic Care, I like those brushes because they have a sonic action that helps with some buildup, but you have to use them properly. You can't use them like a manual. You can't scrub with them. You have to let the bristles kind of just go on the tooth. You have to do it on every tooth. And so I have some kids that really hate the feeling of an electric toothbrush. And so then don't use it on that kid. If they'll do a manual for 2 minutes, but the electric is a fight and a cry, go to the manual. If you're going to give them an electric toothbrush and think they're going to do it all by themselves, and this, is something that you don't have to help with anymore, that's not true either, because they may just stick it on their tongue and sit there for 2 minutes. Also, the cheaper electric toothbrushes, so like a Sonic Care's like a $50 toothbrush, okay? Oral-B makes one, that's a good one too. But all the ones that are somewhere around like 35, 40, 50, those are good brushes. The $15 ones, like the cartoon ones that you get, 15, 5, those are terrible because the mechanics are cheap, and if you touch the tooth too hard, they just stop. And sometimes they're too thick to get on the side of the teeth. So literally I can look in a kid's mouth and everything is clean, but just the buccal areas. And I'll go, "Let me guess, you have a Spider-Man toothbrush." He goes, "Yeah," and it spins. And I'm like, "All right, so that one's not a good one for you." And so you get what you pay for in a toothbrush. That's even true with adult toothbrushes. It's one of the only things you get what you pay for, because the bristles are better. For adults, it's going to prevent recession because they're not going to be as cheap, and the ends are flat. So you actually get what you pay for in a toothbrush.
When you say with a sonic brush, so I should put the bristles against and just hold it there?
Yeah,
and then
let
move to
it
the
do
next
the
point?
work. Yeah, and just make sure it touches everywhere.
So I'm not going across like this. I would just hold it to this part of my tooth and then pick it up and move it to here.
Yeah,
and
or
pick it
just slightly do a little movement.
up. Okay.
But you don't hold it like this.
Yeah.
You hold it more like just very light and let it
Do its magic.
Yeah.
Yeah. And I tell my parents that kids can brush their own teeth because there comes a point when they want to do things for themselves, but you need to brush the teeth behind them until they're in second grade and they can write cursive, because at that point, yes. Okay, good.
Yeah, when the manual dexterity, when they can write as well as you, that's when you don't need to help
brush them anymore.
Yeah. And then they become teenagers, and then you have to check them again.
Yeah. The whole. I remember a mom in my practice. They came from a big family, and we were talking about letting kids become more mature and giving them, like, my daughter wanted contacts, and I was concerned that they were going to get eye infections, and this mom in my practice, she said she'll do fine. And my younger brother hated to brush his teeth when we were in high school. And my parents never said anything. You know who got him to brush his teeth? Everybody in school, because they told him his breath stunk. And so,
wow.
Yeah, so they kind of let the community move it forward, because he wasn't listening to them. He said, "We're not going to waste our breath anymore. We're going to and it came a point when everybody's like, "Yeah, you stink," and then he started brushing his teeth. Yeah. So I don't know. I'm not advising that.
Yeah.
But
I think that's called bullying now, right?
Yeah. That would be hilarious.
That's a whole other topic.
Yeah, that's another one. Yeah. No, why did they bill you? Because I haven't brushed my teeth for 3 weeks.
Well, they should.
Yeah. Well, we're not gonna do this story. Sealants. So children's teeth, deeper grooves on the back molars, and so the sealants then basically act as kind of take away the depths of the caverns at the bottom of the teeth, so then they're less likely to have food stuck there.
Correct.
Okay.
So we seal the 6-year molars, which are the permanent first molars, and the 12-year molars, which are the permanent second molars. Traditionally, that's just what's recommended. You can seal any back tooth, but those are the teeth that have statistically more of a chance of getting cavities, even with the best brushing. So like a baby molar, with pretty good hygiene and brushing, the grooves are very shallow. So the bristle, it's going to debride. But those permanent first molars, some people, and this is where genetics will come in, some people have a shallow groove. Great, you're very lucky. Some people have kind of a groove that's more like this.
V-shaped.
Yeah, and then some will have grooves that go like this, and they'll have little connections way down deep in there.
Wow.
And you can't clean that with a toothbrush. And so microorganisms, things are going to get down in there, food, sugars, and boom, you're going to get cavities. So that's why we do sealant, is because it seals up the groove. And it's the best thing we have. It's just a very thin filling material that just seals up that groove area. And we do it in kids because if we wait till you're an adult, you either have a cavity or you don't have a cavity in there. Yeah. So that's why you always hear kids getting sealant, because we want to seal them as soon as the tooth erupts.
Yeah.
Yeah.
Tongue tie, lip tie.
Okay.
Okay. Happening more in my experience. When I was, 20 years ago, there was rarely a child that had a lip tie. Now it's quite more common.
Yeah.
Is it because we diagnose better, or is it actually happening more?
So a couple of things. So my opinion is everything comes in cycles. And so we know tongue ties have been there for years. Used to, births were done by a lot of midwives. Midwives used to keep a long fingernail, and they would cut the tongue because they weren't allowed to use tools, but they could use their fingernail. So we know that the practice has come around. Now, like in the 70s, there was this push against breastfeeding and more formula, or at least I think it was like the 70s, 80s.
That was my generation.
Yeah. And so I think, less people trying to breastfeed and more push to formula. You probably just didn't catch them because people didn't care as much about breastfeeding. And so now we're back into this idea of breastfeeding is better, and it's a whole food, and it's better for the mouth and the development and the airway, and moms are online and they're learning all these things. So now maybe we've got this idea of, okay, now we need to make sure everybody has the ability. So now we're starting to diagnose them more because of that reason. Also, the folic acid is supposed to be a side effect, and you may know more about that, but doesn't mean you don't want to take that in pregnancy. But I think that addition of the prenatal vitamin is making it more prevalent. That's a good question for you.
So you shouldn't take folic acid if you're pregnant. Okay. Folic acid is not bioavailable. It is a manufactured product.
That is what everybody takes, right? Folic acid.
Yeah. No, that's why I'm getting.
That's what I had to take, right? Yeah. Like that's what the push was. So you're against it now.
Well, no, it's not that I'm against it. So what I'm going to explain. I'm not against it. No, folic acid I'm against because it's not bioavailable. It is it's like a cheap toothbrush. Oh, you're brushing your teeth? Yeah. Well, I'm not asking you what quality of toothbrush you're using or how you're brushing your teeth or what type of toothpaste. So it's just a way to say, oh, it contains folic acid, which then a parent off the shelf who isn't educated grabs it and takes it. But then the body can't turn that into the needed folate that is then used to help with electron transport and the development of the DNA, because we need that transport to be happening in order to make our DNA, make tissues, do the replication of all of our DNA material. And so you want to take folate, not, and then I'm going to go one more layer in. So you want to take folate, because then the body can use the folate. Folic acid is not bioavailable. It's manufactured. Folate is bioavailable. But then lots of people have MTHFR, methyl-tetrahydrate folate, deficiencies, or they're heterozygous, which means that you're either homozygous, you don't have the MTHFR enzyme, you're heterozygous, where you have partial expression of the enzyme, or you're fully homozygous the other direction, where you have full function of the enzyme. And so by having the methyl group on your methylfolate, so you got folic acid, folate, and then you got methylfolate. The methylfolate can just be pulled in without having to depend on the enzyme to bring it into the body.
Okay.
So MTHFR deficiencies, if you have that enzyme deficiency, leads to midline defects. So you'll see cleft palates, you'll see the tongue ties, what else? Heart defects. So, gastroschisis, anything that's happening midline is not completely, because there's a genetic component to it, but it's an MTHFR deficiency, because a third of the population is MTHR homozygous to have full function. A third of the population is heterozygous, has partial function. A third of the population has no function. So that's why we're seeing more and more, because people are relying on folic acid rather than folate. But then if you have a partial enzyme expression or no enzyme expression, then folate won't even work for you, and you have to be on methylfolate.
Okay.
Does that make sense?
Yeah.
Yeah. So that's part of the reason it goes back to the whole foods is, they put in folic acid, and people think they're taking what they need to be taken, but it's just, again, it's a commercial advertising shell game. Unfortunately.
Okay.
We're making $1, but at your expense. Like a lot of things happen. So the midwives, I used to tongue releases back in the early day until you guys pulled out the lasers, and then I'm like, I'm not going to compete against the laser.
Yeah.
So I would clip the frenulum, and then I would have the mom nurse right there, and we would make sure that the latch was better. And the laser, the reason I backed off is like, well, if I'm clipping, it's the same as a laser. But what I didn't understand was that there could be connective tissue beyond what I cut. And I don't know that I know I'm not using the right terminology, that there can be, that the laser is better because it gets deeper, and then it releases some kind of strain or connective tissue that's going beyond what's there. Is this making any sense to you? Or
the laser is gonna heal better. It's not as traumatic. It's not as bloody. It's not it's according to which laser you use, but it's going to stimulate the healing much quicker. So you're also going to have just a happier baby than a baby that had scissors. But it's just supposed to heal better, and you can go back a little further, safer.
Okay.
Yeah.
And then I just had a patient in my practice. They had a reattachment of a upper lip release, and that's one of the things the parents have to do is because remember earlier in the conversation we said the mucosa heals super fast.
Right.
So
you have to do the stretches.
So you have to do the stretches, otherwise they'll just readhese, and then you've really done a procedure for very little gain. Yeah.
So the thought pattern is that if you have a proper latch, if you do it as a baby, you do a lip tie, you do a tongue tie release as a baby. If you have a proper latch, then the tongue tie exercises aren't completely necessary. The lip is still a little necessary. You want to take the lip, you want to lift it over the nares and keep kind of practicing. And what you'll notice is, especially if the baby's a little older, the lip is really tight because it's used to being mushed down and tucked under, and that's where the pain comes with the nursing. And so if you've got to almost do a little baby massage and relax that baby and relax that lip, and that's where like really diving deep with a lactation specialist, you want to couple all these things. As a dentist, we pretty much we cut, we laser. The therapists, the lactation consultants, those are the real heroes. Those are the people that really make all of the tissues do what they're supposed to do. Yeah.
Yeah, to get the complete. It's like
Yeah.
it's like, okay, the cardiac surgeon put stents in my blocked heart vessels.
Yeah.
But then you really have to go and work with a lifestyle specialist after
Yeah.
that and make sure that you change your diet, your exercise patterns, your stress loads, because that's really what's going to keep you off of the table again.
Yeah.
And keep you alive. So kids love to put lemons in their mouth.
No.
Right. That's where I was getting. It is like you just see the kids with this like sucking on lemons, and that just eats enamel. No?
Yeah, I've actually seen kids that. So you take a kid to a restaurant and they're sitting there. It's a long meal, and they want up. And so what's the mom do? They've got a lemon. They go, here, take this. And so they sit and they just suck and play with that lemon at the table. And I've actually seen a couple of kids that looked at their teeth and there's no cavities in the back. There's just this erosion. And I went, does he suck a lot of lemons? And it's like, yeah.
Mm-hmm.
And so it will erode the enamel. I mean, once or twice here or there, but you eat dinner out every night and you give him a lemon for 30 minutes every day. Yeah.
That's going to add up.
Yeah, that can add up. Yeah.
When is there a way to rebuild enamel? I mean, obviously, then other than having your adult teeth come in.
No, not if it's eroded away. Now, if you have like pre-cavity, there's way to fluoride and hydroxyapatite and things can remineralize enamel. But if in pre-cavity, those like white spot lesions, but like acid is going to just erode the enamel. It's just gone.
And the hydroxyapatite. That toothpaste. It's just like fluoride. You'd leave it on your mouth. You'd leave it on the teeth after you're done.
I would use it just like fluoride. It's supposed to perform the same as fluoride. I mean, that's what all the literature says. Do I know that for sure? No, because sometimes I just don't have great sample size in my office. So I'm not conducting a research project, but I'm looking at some of my patients and going, okay, you're a fluoride family, you're a hydroxyapatite family. But there's so many differences sometimes in those different families that you can't.
Too confounding.
Yeah. So like, okay, these kids go to public school. These kids are homeschooled. And so homeschool kids have free range to eat all day. Kids in school are made to only get water between meals. They get water bottles. They get, so many hours without contact with food. So, they're obviously going to have less cavities versus somebody that can literally eat all day or drink milk all day or drink juice all day or something like that. So I can't decide for myself, but in the literature, hydroxyapatite is supposed to be equivalent.
Okay. I didn't know that.
Yeah.
I thought that was more for remineralization.
Which is like basically what fluoride's doing. It's bonding with the enamel and changing the enamel to be a harder substance.
Okay. All right.
Okay.
What about these teeth whiteners? Because my kids will order a teeth whitener.
The recommended age is 12 and above, and they haven't proven that there's any problems with teeth whitening. It's been around for a long time. And so there's no contraindication. Why is it 12? Because that's a magic age. 6 and 12 are like magic ages for FDA approval of things. So 12 is pretty much the magic age, and not during pregnancy. They don't recommend to whiten your teeth during pregnancy.
Is it teratogen?
I think either they feel like could do something, or they just don't want to do testing.
Yeah.
Yeah.
And can that cause enamel erosion?
Teeth whitening? No.
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 No. Okay. All right. That's good to know. The last question. It was oil pulling. Does that have I mean, I will agree.
I don't know that much about oil pulling, really. I just, the only thing I caution is that what I'm seeing is people that start a holistic approach already have a problem. So if you already have a mouthful of cavities, you can't do a preventative
Too far
treatment.
gone.
You can't make deep cavities go away with coconut oils or they just don't. Once it's gone past the enamel into the dentin, into the pulp of the tooth, I mean, it's too far gone. It needs to be fixed. If and so I'm not seeing anybody doing really deep, holistic treatments until they're already in trouble. And then it's like, would they have worked as a preventative? I don't know.
Yeah. I wasn't looking at to solve cavities. Oil pulling will have a benefit if you're in a fasting state. And so when you're fasting, your fat cells collect the toxins, because if it's a water soluble toxin, you'll just pee it out or you'll sweat it out. But if it's fat soluble toxin, you don't pee it out. You don't sweat it out. It gets stored in your fat cells. So when you haven't eaten for 12 hours and then you oil pull first thing in the morning and you do it for 15 minutes, the toxins that are now circulating that have been liberated from the fat cells are saying, oh, there's fat over there. I can go over there. And then you can pull them through the mucosa and then you spit out. So there's an element, but that's more on my side of the fence and your side of the fence. But then there's also
much about that.
the oil over the teeth as a preventive to prevent cavities, not to fix cavities.
Yeah, that's what I'm getting is I'm going to fix these cavities. And I'm like, that's not going to happen.
I'm not with you on that. Yeah, I mean, I'm not with that perspective.
Yeah, it's kind of like you broke your knee, it's broken, it needs fixed, it's like, or, strengthening your knee and doing all these exercises to prevent, whatever movement that would break your, I don't know. It's too late.
Yeah, too late at that point.
Yeah.
Yeah. Well, those are all the questions that I can come up with. I think we covered a lot of
You hit it all.
Yeah. Well, that was informative. I learned. That's good.
Well, that's great. I learned a lot too. So,
yeah, good.
Yeah.
Yeah. So we know we have to do better toothpaste information, education. I do. And I will start referring babies to the dentist for sheer life.
We love babies.
Yeah, babies are the best.
We love babies. Yeah.
That's why I'm a pediatrician.
Well, yeah.
Yeah. It was like old men or babies. It's like,
exactly.
there's no choice there.
Exactly.
I just had I have medical students come through my office, and I haven't had a pediatrician want to be yet, and then they're like, oh, I want to do adult GI, and I'm like, oh,
really?
Oh,
ugh.
Oh, who wants to do that? No, but that's why we have different people to do different things.
Absolutely, yeah. My sister loves geriatrics. She's a nurse practitioner and loves geriatrics and psychiatry and stuff. And I'm like, no, give me a little kid and
yeah. I had one of my best friends when we were both in med school. He was in dental school and I was in medical school, and I guess you guys have to carve a tooth or something, a molar, right? You know what I'm talking about?
Not just one.
What, right. And he came in. He said, "I got 100," and I'm like, oh, "Great," not thinking much about it. And he says, "No, you don't understand.
No, that never happens.
That doesn't happen."
Yeah,
and he said, "My teacher said, there's no such thing as a perfect tooth, and you just made the perfect tooth." And he got 100. So that's the only thing that sticks to me from his dental experience. But he was blown away. He goes, "I got 100." He's like, nobody gets hundreds. Yeah.
No,
nobody gets hundreds. There's no such thing as a perfect.
Something. Yeah.
And he goes, "I carved the perfect tooth." And I'm like, wow, that's great.
And you didn't realize it probably took him literally 8 hours.
Probably.
Yeah.
Yeah.
Over weeks to do that tooth. So.
Yeah. Oh, I could tell stories from the dental school. If those guys were funny. Oh, they were a lot of fun. The dental guys. One guy was just unfortunate. He my best friend from growing up's little brother, and their dad was an orthodontist, and so he wanted to be an orthodontist, and he played football. He was a big kid, and you have to wear outfits, and so up in the student dental clinic, and so he, the lights on him, and he's just dripping sweat on his patients, and I was like, what are you going to do about that? Because he's just learning his skill craft, right?
Yeah,
and I'm like, dude, you can't just sweat over the top of people. He's, oh, I'm sweating all over them. And I'm like, what are you going to do?
I had a partner like that. He wore a headband.
Yeah.
He finally wore a big tennis headband.
Yeah, Bjorn Borg.
Yeah.
Yeah.
Because he was just
dripping sweat all over the patients.
Oh,
yeah. Yeah, we don't need to include all that. That's sidebar.
Yeah.
Anyways, well, thanks a lot for coming. And or maybe you can't include it. It's just kind of funny stuff.
kind of
We're not sweating on people. We can make
No.
fun of the people that are.
No.
All right. Well, I guess I'll see you at your office at some point.
And I'll see you here at your
yes,
office with
yeah.
my kids. Yeah.
All right. Well, thanks a lot. Have a good weekend.
Thank you. You too.
Awesome. Thank you for joining us on the Dr. Thornburg Wellness Podcast. Come for the science and common sense. Stay because it works.